This lecture, we're going to talk about evaluation and management levels or guidelines and outpatient and inpatient billing and coding basics. So a lot of this stuff can get pretty dense, so just bear with me. You'll learn as you're working in certain care areas and with the same physicians that a lot of this stuff will then become very easy to you because you're coding the same things, you're billing on the same procedures, etc. So before we start, I just want you to ask yourself these questions and check your baseline understanding. And if your baseline understanding is I have no idea, that's fine. Like I said, as you work in the industry, as you work in the same care areas with the same physicians, you're going to learn more and more about these things. So what are evaluation and management levels? Why do they matter to the medical scribe? And what are some of the billing and coding differences between outpatient and inpatient settings? So first, let's just go over some acronyms that you need to know. So ICD-10. So this is the 10th version of the International Classification of Disease, which was created by the World Health Organization. It's numeric codes assigned to any diagnosis or condition that a patient has, past or present. And these codes are used to justify billing of a CPT code to third-party payers. CPT code, or current procedural terminology, are very important from a billing standpoint. It's a 5-digit code for procedures and services provided by the care provider, clinic, or hospital. All CPT codes must be justified by appropriate ICD-10 diagnoses or symptoms. This is called medical necessity and is required for payment and reimbursement. So what this means is if ICD-10 code is coding for a left arm fracture and I put in a CPT for a right ear irrigation, that doesn't make sense. So, and conversely, if I say the ICD-10 code is for left arm fracture and CPT code is left arm x-ray, that makes sense. So this is how we make sure that we are getting reimbursed for the services we're providing, but everything has to match up and make sense. So let's talk a little bit more about evaluation and management levels. Now let's talk about the key components of E&M services. So there's history, examination, and medical decision making. The first three components, history, examination, and medical decision making, are key components in selecting the levels of E&M services. In the case of visits consisting predominantly of counseling or coordination of care, time is key or a controlling factor to qualify for a particular E&M service. So this is when we document 30 minutes smoking cessation counseling done with patient. Generally that kind of counseling wouldn't take that long, but you get the gist. You want to account for time. Because of the level of E&M services dependent on 2 or 3 key components, performance and documentation of one component at the highest level does not necessarily mean that that encounter in its entirety qualifies for maximum level of E&M services. So even if I'm doing a thorough exam, if the other components of E&M services are not reaching the level of higher reimbursement, it's not a high level visit. Again, other things that are taken into consideration: counseling, coordination of care, nature of problem presented, and time. So some of the questions you'll want to ask yourself when documenting to determine an evaluation and management code. Is this an inpatient or an outpatient visit? Is this a new or an established patient? And how complex is the evaluation of the patient? So a new patient is anyone who hasn't been seen by another provider in the billing physician's practice group in the last 3 years. So even if I was a patient at this clinic 4 years ago and I come back, I'm now considered a new patient. And this is important to know because new patients are billed higher than established patients. And the reason being, you have to get a lot more information from a new patient. You have to get their full history again. What has happened in the interim if you haven't seen them in 4 years? their medications, etc. It takes a lot more time and effort. The higher the complexity of the patient, the higher the E&M level. So keep in mind for the physical exam, there must be 2 documented findings within each system. So an example of a physical system would be cardiovascular, the heart. 2 findings in that system would be S1, S2, regular rate and rhythm, no murmurs, no rubs. There are multiple things that need to be documented in that area. It can't just be regular rate and rhythm. It can't just be sinus rhythm. There has to be at least 2 documented findings under each physical exam system. So again, when determining complexity, we're looking at things like history, exam, and medical decision making. So the things that you can really pay attention to in your documentation is going to be important is history. You're listening to the questions the physician is asking the patient. You're making sure that you're writing down all history, not pertinent history, all history. You're listening to them as they do the exam. You're confirming with them, oh, is this what you assessed, and documenting that. In medical decision making, that's kind of made on the back end, that determination, and it's really made by the physician themselves. But the parts that are going to be really important for you as the medical scribe is going to be history and physical exam. And the point is, documentation is key. Thorough documentation is key. So here's an example of the different levels for new patient billing criteria for primary care. So everybody will have a chief complaint. So that's CC. Chief complaint is just the reason why the patient is coming. My stomach hurts. I have a headache. I have had headaches for a week. That's their chief complaint. So everybody should have a chief complaint. And we'll look at a few other chart examples on the next couple slides. So here you can see the established patient billing criteria for primary care. So you can see the variance among the levels is very similar for new patients, but it's not as necessary to reach a level 1. So level 1 in this case would probably be the patient's chief complaint is, I'm here for a flu vaccine today. You don't need to get history, you just need to get consent. Physical exam does not need to be done. They're simply given a flu vaccine, most likely by the MA, not even by the physician. So you can see some of the differences here. And here's the billing criteria for emergency department encounters. You think about the reasons why people go to the emergency room, anything from I need stitches to some terrible trauma, and you can see how that would be reflected in the levels of care here. Things to remember or consider. So a history of present illness containing 5 or more elements. So OPQRSTA here is what we're using. So O for onset, P for provokes, Q for quality, R for radiates, S for severity, T for time, A for alleviates. So this is in general when it comes to pain, the questions that they would be asking the patient. But these descriptors meet criteria for a level 4 or level 5 visit. Catch-all, quote-unquote catch-all phrase like a complete review of system was obtained in negative may sometimes be documented in lieu of a complete documentation of all 14 systems. So a review of systems is generally what a patient will fill out on their way in, like, have you had nausea? Have you had vomiting? Have you had fever? And they'll say yes or no. But there are 14 different systems that they fill this out for. So review of system requirements can be completed using a patient filled out form as long as it is documented in the chart that the complete review of systems form completed by the patient was reviewed by the physician. 2 documented findings for each body system in physical exam, which I already discussed. Now let's talk about medical decision making and your role in it. So there are generally three components that we're looking at when it comes to determining the level of medical decision making: the number of diagnoses or problems, review of data. So is there a lot of labs? Is there a lot of imaging? And risk. So for each diagnosis, it is important to document if the issue is new or established, stable, deteriorated, or improved. So this is where you come in. You need to make sure you're documenting this. It is imperative that you catch all problems discussed between the physician and the patient and their associated qualifiers. A billing coder will use this information to input into an algorithm to determine on a point system what the medical decision making or patient complexity will be billed as. So again, this isn't your job to determine the medical decision making or the level of complexity. It is simply your job to make sure that you are documenting every issue fully and accurately, so that it can be billed appropriately. So a total of 4 more points from this list below qualifies as a complex medical decision making, and therefore will meet higher billing requirements. So a minor problem is 1 point, an established problem, stable or improving, is 1 point, and a worsening established problem is 2 points, a new problem without planned evaluation is 3 points, and a new problem with a plan is 4 points. So review of data when it comes to medical decision making. So the information is reviewed to determine the complexity. Your job is to recognize and document about the review of current tests and or outside records. And some EMRs and EHRs will have the phrasing incorporated into the documentation. However, in some cases, it might be needed to be documented manually. This is also objectively evaluated on a point system. So things like review of radiology tests will be 1 point. Lab tests reviewed will be 1 point. Independent review of an X-ray or EKG will be 2 points. Review of a test with other physician that performed the test will be 1 point. Simply the attempt to obtain outside records will be 1 point, and the review and summary of those outside records will be 1 point. And you can see the different complexities to the side here. If I get 4 points, that's a complex complexity. So what I want you to take away from this is it is imperative that you document every time the physician reviews labs, every time the physician reviews radiology, every time the physician requests outside records, because it's going to accumulate to lend itself to what the complexity of this patient is. And risk. So can be based on the severity of the problem, something like immediate suicidal thoughts, considered very high risk, or the invasiveness of tests, so something like CT angio, the risk of treatment, so a medication that requires extensive monitoring, like anticoagulant therapy, such as warfarin or TPA if you've had a ischemic stroke. It's important that you pay close attention to any risk-based discussion or dictation by the provider. If a component is high risk, the entire visit is considered high risk. So the medical decision-making requirements for an evaluation and management level of 5, 2 of 3 of the following criteria must be met. So complexity of the problem as determined by points, complexity of the data reviewed as determined by points, a high-risk problem, procedure, or treatment. Again, it's not necessarily your job as a medical scribe to determine the level of medical decision making. It is your job simply and importantly to make sure you're documenting everything thoroughly so that differentiation can be made on the back end. Let's see some ways that inpatient billing and coding differ. You could see how some of it differed on those initial charts I showed you, but we'll take a closer look. Inpatient billing and coding. So emergency departments and clinics are actually considered outpatient. Hospitals and hospitalists are considered inpatient and have significantly different billing systems. In either environment, how well you do the job of collecting and documenting information thoroughly may directly affect reimbursement rates for medical insurers, from medical insurers. CMS insures the greatest number of Americans, and its billing methodology sets the bar for many private insurance companies and HMOs. So in 2008, CMS implemented the Inpatient Prospective Payment System, IPPS, which reimburses hospitals based on principal discharge diagnosis. Patient gets placed in one of 747 Medicare Severity Diagnosis Groups, MSDRGs, and hospitals are then compensated by MSDRGs rather than in the individual patient. This is working off the assumption that patients with similar conditions are expected to have similar resource use and clinical patterns of care. Principal discharge diagnosis is defined as that condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital for care. Capturing full reimbursement with secondary diagnoses. So MSDRG is an overarching billing category, but a range of reimbursement amounts exist based on the other health conditions of the patient, also known as comorbidities. Secondary diagnoses are that are managed during a patient's hospital stay are classified as one of the following: a major complication or comorbidity, MCC, a complication or comorbidity, CC, or neither MCC or CC. Principal diagnosis determines overall billing rate and is rarely ever missed, but secondary diagnoses are missed or overlooked up to 50% of the time. So this is when it comes into play that you need to make sure, if you're following a hospitalist or a physician that's seeing patients in the hospital, that if we are treating something other than the reason they're in the hospital, there's, for treating a comorbidity, that we're documenting on it. So what makes it an MCC? So we have manifestation of disease, episode of care or acuity, and site of affliction. So manifestation of disease, the symptoms exhibited by an underlying disease document both the symptom and disease if known. For example, chest pain secondary to pneumonia, noting a causative organism of infection, UTI secondary to E. coli. Episode of care and acuity, acute versus chronic. So just happening or happens all the time. Address of the condition is new or chronic. If a chronic condition is worse than baseline status, it can be labeled acute on chronic or acute decompensation. And site of affliction, although obvious, often missed. For example, a patient is admitted for acute exacerbation of congestive heart failure with the secondary finding of lower extremity cellulitis. If documented as cellulitis requiring IV antibiotics, it lacks an acuity and episode of care and the location. This information is sufficient for communication with the medical team, but insufficient for reimbursement. So you would need to be more specific. Lower, whatever, left or right lower extremity cellulitis requiring IV antibiotics, secondary to, whatever is causing it. It needs to be as thorough as possible. Maximizing billing for the hospital as a whole. So reimbursement rate determination is calculated by using a weighted multiplier. So you can see the formula right here. The multiplier adjusts for regional differences in cost of living, employment, and real estate. It does take into account the general complexity of patients in that region and the speed with which patients improve and are discharged. Particular variables reflected in these factors are the case mix index, severity of illness, and length of stay. These are just a couple commonly underbilled conditions. So common error number 1 is multiple sites of malignancy or fracture. So malignancy of multiple sites versus listing each site of malignancy. So that's like you have lung cancer with metastasis. Well, where did it go? Where is that cancer now? You need to list all those places. Individual notation equals individual reimbursement. Example, so somebody has rib fractures. Instead of documenting multiple fractures, you should note left lateral ribs number 5 through 10 fractured. Then that's 5 places that are fractured. Common error number 2, grading conditions, including the stage of the disease and documentation. Is it acute or is it chronic? So you can ask your physician what stage of CHF or what stage of chronic kidney disease the patient is in to include in the documentation, and if it is acute or chronic. Again, it's not necessarily your job to know if it is. It is simply your job to note with the physician, okay, how do you want me to document this? Is this new? Is it a chronic condition? Is it worse than baseline? What stage is it in? Hospitalist and internist billing levels. So billing levels are based on time. It's less common. There are 3 levels in critical care time. So critical care time must meet the following criteria. 1, direct delivery of medical care. 2, critical illness, one that acutely impairs more or equal to 1 organ system. 3, high risk of deterioration. And 4, complexity of medical decision making. Time spent counseling, verbal comfort, instruction, all of that counts towards time. You're not really setting a timer. You're not hitting a stopwatch. It's recorded based on the honor code. So you can see how this can get a little dicey, but we work on the honor system. Billing levels based on complexity of care and documentation. Saying that we work on the honor system also means that we need to make sure that we're documenting everything that's going on, so that when we're like, oh, physician was in here for 30 minutes, well, why? You didn't document anything that they did in that 30 minutes. Billing levels based on complexity of care and documentation. Far more common, same 3 levels, except for chief complaint time, or critical care time, but with more complex rules, and you can see that here. So critical care time is also defined as direct delivery of medical care for critically ill or critically injured patient. A critical illness or injury acutely impairs 1 or more vital organ systems such that there is a high probability of imminent or life-threatening deterioration in the patient's condition. So I can't bill critical care time if I'm stitching up somebody's knee gash. It has to be something that, if we're not treating it quickly, the patient could die. So let's talk about it. How does this apply to you, the medical scribe? So I've kind of been reiterating this throughout. This is super dense. It's really difficult, even for experienced clinicians, to figure out. So it's not necessarily it's not your job to figure out the medical decision making, the complexity of the visit. It's your job to make sure that you're documenting everything thoroughly. If you're unsure, ask your physician, hey, how many systems did you do? Remind me what the findings were. It's your job as the medical scribe just to make sure you're fully documenting everything that is happening between the physician and the patient. Any questions, comments, or concerns, feel free to let me know.